All right, I'm going to get started. My name is Terry Fortin, and I've been at the Duke Pulmonary Vascular Center for the last 25 years. I am a cardiologist, and then I'll have a panel. So my talk part of this will be brief, but we're going to talk about combined pre and post capillary pH, and mostly we want to focus on what's really going on when we see these patients, and less on the data because we don't have a lot of great data. Okay. There you go. Okay. So CPC-PH, i.e. combined pre and post capillary pH, as the definitions for pH change, the definitions for this change. So pre-capillary pH we know is a mean pH pressure greater than 20, a wedge less than 15, and now a PVR of more than 2. For isolated post-capillary pH, which is basically pH with left heart disease, right? The mean PA pressure is high, it's greater than 20, but the wedge is high, that being the difference, and PVR is normal. So some of our left heart failure people are that, and they don't have more any pre-capillary pH. But then we have this group that we call combined pre and post capillary. So their mean PA pressures are elevated, their wedge is elevated, but their PVR is also elevated. And the degree of those things varies tremendously. And so somebody mentioned that all those heart failure people are the same. And certainly we know in HFpEF for years, in HFrEF, when we have low EFs, we have many meds that have helped that for years. And we struggled through many studies using those same meds to try to treat HFpEF or people with preserved ejection fraction, in part because those people really aren't the same. And now we can say SGLT2s help that, MARs help those, okay? But less data in this space. So this tells us pre-capillary, which would be disease on sort of the upside of this, on the small vessels where, just before we are getting to the capillary bed. And those are our group 1 PH people. Left heart disease people, if your left heart pressure is high or your LA pressure is high, pressure in the venules go up. And then we have this mixed population, our combined group, that this starts first and then this happens as well. It doesn't happen in everybody. So these are the same definitions that we just talked about. And then just a refresher for the non-cardiology people in here or nurses, that when we're talking about PVR or pulmonary vascular resistance, we're taking our cath data, taking our mean PA pressure minus our back pressure, the wedge pressure, and dividing that by cardiac output. So all of those things matter. How big is the wedge? What is the cardiac output that is driving that? I'm going to focus more on this. Whoops, sorry. Now I did it. There you go. This photo here. So another way of looking at this, right? Our RA, RV, and then our PAs, pulmonary arterioles, are where the disease is in pre-capillary, right? And post-capillary, there are problems with the left heart creating this. As changes happen in these venules, that pushes back into the PA, but more than that, it can then also cause actual physiologic changes there. You can think of it as a continuum, but I don't know if it's really a continuum. So left heart failure is a huge group of people, some of whom are going to then get this just isolated pH. Some of them are going to get this combined pH, versus just our pure pH people. So the pathophysiology initially, right? If my wedge is high, then my PA pressure has to go up some, right? If I pump blood to the lungs and blood flows passively over to the left side, if the left-sided pressure goes up, this has to rise with it. Over time, your people will protect themselves to try to prevent pulmonary edema. You'll get some vasoconstriction perhaps, and your PVR will go up. But on top of that, you also get remodeling of those vessels. So the venules will get thickened. There's a bigger fibrin deposition that happens, less cellular. And then that can start to happen in the arterioles. Biopsies or will show some difference in what PAH looks like, which is a more cellular intraluminal process than what the other is. And then we'll see the same hemosiderin that Dr. Mathai brought up in these folks as well. Okay. We may also then get some destruction of vessels from other concomitant diseases that occur. Sudar went over some of this data. So huge amounts of people have PH, not necessarily PAH. The incidence is about 5 to 10 cases per 100,000 people in the US and account for many of these cases. CPC-PH is more associated if we take all of the people with this or with PH and say who is going to get this combined pH, if there is a lot of metabolic profiles, i.e. hypertension, diabetes, obesity, AFib, valvular heart disease, those things will increase that. Sleep disordered breathing increases that. So if you have patients that are coming to you and the question is pH and you're like, oh, maybe this left heart, but they have all these other things, a signal to look for this. It's important because mortality in these folks compared to just people with left heart disease is certainly higher. And so we do need to think about that. A good proportion, because left heart disease is so common as people get older over the age of 65, there's this huge amount of population that's out there that we're now going to be including. Okay. In some of the older literature, diastolic pressure gradient, so the difference between my PA diastolic on a cath and my wedge, if that is high, it's a sign of perhaps this combined pre and post capillary, or if your mean PA pressure and your wedge are very different, also a sign that there may be some mixed component. Okay. I think this that treats this in that this isn't just one thing, right? We have our isolated precapillary here, whether they're group 1 or 3s or 4s, and then our catch-all group 5s who are renal disease or hematologic issues. And then our post-capillary people over here. Again, not all these group 2 people are alike, but there's certainly some overlap between these groups in terms of presentation with this disease. So who in your clinic, this is what we want to get at. This is in the real world, what happens. So we have our true group 1 patients that maybe we've followed for years and they're clearly idiopathic, or maybe they're clearly scleroderma PH, and Steve alluded to this. Now they develop other diseases as they get older. So maybe now they have coronary disease or they have valvular heart disease and their pH is no longer as pure. They start to get, AFib, diabetes, all the things as patients get older in the US that are going to contribute to that. Some of these people are chronic LV systolic heart failure for years. Some of those people have non-ischemic cardiomyopathy and may have a lot more right heart involvement than others. And then we have this big bucket of people who have HFpEF. So their EF is normal, but in women, people with all those same things, hypertension, AFib, diabetes, they get a wedge pressure that can variably be very high. We also have populations of people, especially in people who are in advanced heart failure clinics or in heart failure, where people have terrible left heart disease, and now we've fixed them, or we've done something to try to fix them. We've put them on inotropes, or if they fail that, they move on and they're sitting with an Impella in the hospital, or they have an LVAD in their home. And by an LVAD, a left ventricular assist device, for those of you not familiar with that, and they basically have a heart pump. So we've unloaded their left side, and yet some of those people continue to have some degree of pulmonary hypertension that is problematic and may prevent them going on to transplant. Some of them have it bad enough that maybe prevents them from going to an LVAD, okay? And then we have, if we think about who has heart failure, either systolic or diastolic or both, many of those people are older, not all of them, but who gets ILD? Older people who, all these COPD folks that smoke for years as they get older, get heart disease and lung disease. And if you put the two of them together, your risk of CPC-PH certainly goes up. I think sort of repetitive of the same things. The only thing I would add is that there seems to be some genetic predisposition. So there's some studies looking at different genes in folks to see is that what makes them different, right? Why does somebody with left heart disease have it for 30 years and they do well and their EF is 25 and they walk around like there's nothing wrong with them, and others succumb poorly, and some develop right heart issues and some don't. Seems to be more common in younger women, and maybe PH was PAH in younger women. They're more likely to have it. This is sort of to this genetic predisposition. Why does this person get PAH also in addition to their left heart disease? Okay. Someday maybe we'll look for those things in advance so we know who they're going to be if we ever know how to treat it. Why do we care? We care because the mortality and morbidity is higher in those people. So if we have left heart failure people and they start to develop it, it makes it hard to offer them some of the other treatments they could get, but their mortality is certainly higher. Should we treat these people? Should we give them PH medicines? And if we are going to, who do we give it to? Do we need to change management in our patients who have clear pulmonary arterial hypertension and have done well for years, and now they have a heart attack, or now they have AFib or something else? Misclassification, we'll talk about in a minute, is a problem in terms of, is this person really PAH and I should be treating them with endothelin antagonists and prostacyclins, or is this really left heart disease and I'm not doing a very good job with my diagnostic techniques? And as we have changed the definition of PAH, right, we've lowered that pressure to 20 because there's clearly morbidity and mortality that we see at that inflection point, and it helps us recognize true pulmonary arterial hypertension. But as we do that, I've had people that I now say, oh, I capped you before and I didn't treat you with your scleroderma because we couldn't get you in that. Your PVR was 2, and now you're in the bucket and I can treat you. But at the same time, are we not going to give people all of our left heart medicines, right? So if somebody really has left heart failure, we have very good medicines that help those people. And if we're throwing in the bucket and calling them PAH, and we're not using all of the goal-directed therapies that do help them, then we're doing them a disservice, okay? But at the same time, if we're not recognizing that there's this second thing, it's a problem. So we should definitely, if we get these people in this bucket and we're not sure, or if there's both, we still need to definitely optimize their left heart failure management before we move on and say, all right, I'm also going to try to treat this arterial component. What is the data for this? The data is very difficult to read. People have tried shunts in left heart failure to try to unload that. In some of those people, there was some small degree of pulmonary hypertension or exercise-induced pulmonary hypertension, and those people didn't fare well with that, so we have to be careful. There are some data using things in people who are now supported, right? We've put them on an LVAD, and now we've unloaded the left heart, so we can worry a little bit less about whether we're going to make them worse. Pulmonary artery denervation has come up, and it's not flying. So while it had immediate sort of changes in pulmonary vascular resistance, in the long term, maybe it is not. Some people are using CardioMEMS to try to help manage these people in left heart failure. A lot of folks use it. Some are using it in PH. Some in these groups in between may help as well. And then medications, again, we have old studies where the first study where IV prostacyclin worked in PH and people have left heart disease, said, oh, maybe we should try that in our heart failure people. And there was increased mortality. Endothelin antagonists were first designed to look at hypertension and then at left heart disease, and the trials were not positive. And then they moved on to luckily for us, they moved on to the PH crowd and said, let's give it to them. Same PDE5 inhibitors. There's little trials that say, yes, it's fine to do. Sudar pointed out that maybe it's not so fine to do in all of these people. in the ESC ERS guidelines, not recommended that we're using that as the last recommendations. But in the real world, I'm not sure that that's what happens. Things are a continuum, right? There's typical IPH in the red and true left heart on the other side, and things in between. And as we discussed, looking at their other comorbidities maybe helps us. Do we try medicines? Do we not? And probably it meets somewhere in the middle. Okay. All right. I would say a few precautions. We need to make sure that I think the common call when I get a consult in the hospital is that, hey, we just cath this. The heart failure team calls and says, hey, we just cath this patient. They have pulmonary arterial hypertension. Can you come treat them? And we have to be very careful that we're not doing all of the workup that we need to, right? Did they have PFTs? Do they have interstitial lung disease? Do they have all of the other things that we need to treat? Are there clues on all of their other imaging? So just because you cath them today and their wedge is normal, it probably isn't all of the time. And, are there things on their echo? Is there LVH? Is there LA huge, like Steve's patient, right? Is there grade 2 or 3 or 4 restriction on their echo, which is very telling in terms of we could make that wedge change with very little fluid or very little change in blood pressure. Okay. Is their RV normal? Does it look like a PH RV like Val's patient, or does it look like a normal RV? Okay. What does their imaging look like when they came to the hospital, not a week after they've been to the hospital and we have a wedge? So we need to look at all that other data before we make our decision. And then look at the context of everything that is going on. Are they hospitalized and they're here and they're really hypoxic because they're having an ILD flare, or they have, quote, pneumonia? All of these things need to be thought about before we jump to things. So think about the context of the right heart cath that you're now being asked to look at all the other data involved before you describe. Now I have a bunch of cases here, so I'm going to bring up a panel to help. I know what was done with these patients, but see what people would do. So I'm going to have Ted Frank. Ted Frank has been with the Sanger Heart Clinic in Charlotte forever. Come right up onto the panel here, Ted. He is an exercise fanatic and has raised loads of money with fundraising for his heart failure group. He does advanced heart failure, transplant, LVADs, all of that, as well as pulmonary arterial hypertension for, I think, longer than me. And then also, we're going to bring up, whoops, let me get everybody. David Ishizawar. David is at UNC. He has come from afar. He was up in Wisconsin before that, and Pittsburgh before that. He also does advanced heart failure. He is at UNC, but also at UNC Rex, and treats PH and advanced heart failure as well. And then Ben Trichon. Oh, here he is. Okay. Ben was a fellow with me in cardiology, or 1 year ahead of me, I guess. And he has been at Mission out in Nashville for many years, but we were lucky enough to have him recruited back to Duke. And he is at Duke Raleigh and in charge of advanced heart failure and pulmonary hypertension there. So I have a couple cases, and I want to get your guys' opinions or thoughts on these, and any questions from the audience at any time. Okay. I'm going to take this down because again, all right, this first lady I just was consulted about. This was her cath. So they did a cath and they called and said, hey, you need to come. The advanced heart failure team called me about this, or a young woman. So this is her cath number. So her aortic blood pressure is high. Her mean aortic pressure is 97. Her cath looks pretty good, almost, borderline as to whether this is combined PAH. Maybe you'd call it straight up PAH. So RA is 3. Her mean PA pressure is 35, right? So greater than our 20. Her wedge is right at that 15 cutoff. She had a cardiac output that was actually good, surprisingly, and an index that's normal. Although, to be fair, she was on dobutamine for 4 days in the hospital, and a PVR of 4.3. So should I break out the idiopathic PH meds, or what else do you want to know about this person?
Does she have the HFpEF or HFrEF variety?
Yeah, so David says HFpEF or HFrEF. she's actually the HFrEF for half in the middle. So she had a prior MI actually, even though she's young. She got stents to her LAD. Initially, her EF was less than that, was probably 35. It has recovered to 45, so sort of at that cusp. Her RV on an echo at this admission is actually normal size and function. Okay. What else you want to know?
Other demographics. It doesn't,
Other demographics, so she's an African American lady, does not have any sort of autoimmune disease. I think some of those, she is thin. She does not have sleep apnea. She's not overweight, does have diabetes, does have hypertension, no lung disease, although is a smoker.
And does she ordinarily live with a blood pressure of 170 with a MAP of 97?
I think that she probably does because she is not the most compliant person with her medications. So it's not always that when she's at clinic, but it's not infrequently that when she shows up.
Then are there any other social history or social factors?
Social factors. She actually works as from home on the telephone, setting up people's medical care post hospitalization, although doesn't necessarily set up her own medical care, but is walking around in the community and fine. Prior to this admission, though, for about 2 weeks before she comes in, she doesn't weigh herself at home. She doesn't follow all of the rules that are set for her. Did put on considerable fluid before she came through the door. So her echo also had moderate MR, grade 3 restriction, which for the non-cardiology people, right, we use some methods to tell us, does the heart relax well or not? So grade 1 would be a low amount, grade 4 would be very stiff heart, grade 3 is pretty stiff. So hypertension, tobacco, some CKD that maybe is 3 for the most of the time. So the other things so when I went to look at her, I said, okay, well, I'm skeptical because of her history. There's left heart disease. So she had a CT. She was hypoxic when she came to the hospital. She is not normally. She has a CT scan, which I may have a picture of, with pleural effusions, pulmonary edema, and I might have an x-ray. And before we did this cath, she was there for 3.5, 4 days, and she wasn't initially peeing, and thus the dobutamine was started, and then she came down 17 pounds, and she's a thin lady in the 3 or 4 days prior to this cath. I think I have her chest x-ray. Her hemoglobin is also 8, and she is chronically anemic. She doesn't take her iron. This is her x-ray about 3 days before we did this cath, and said that her wedge is 15. And now her RA pressure is 3. So what do people think?
Yeah.
I mean, it certainly seems like the type of patient.
This came from your service bed. No, I'm kidding.
Yeah, probably did. I would just put them on sildenafil and discharge them. But no, I think in this type of patient, the first focus is trying to optimize the state of their left heart disease, and you have a lot of room to move in that direction based on her low ejection fraction. She qualifies for ARNI, SGLT2, maybe not GLP-1 if she's not obese. The other thing that I would want...
He has been prescribed all of those things, but questionable
working.
use of all of those things.
And I guess the only other thing I might also say is just making sure that we really think her mitral regurgitation is truly moderate. And if there's any suspicion based on chest wall echo that it may be more than that, and just being rigorous about transesophageal echo if you think that may be underestimated.
Yeah, I was going to say, I think the context is really important here. This one has pulmonary edema. She has bilateral pleural effusion. She has clear left heart disease. And I oftentimes put in my notes about right heart cath, in what context was it done in? So I'm going to say they have pulmonary retention, but they
Thank
have
heaven. You're the only sane person here. No.
Yeah,
Yeah.
and it's really, really important because sometimes in epic things just are, you don't give the context. So in this situation, I guarantee her wedge was higher before. And her phenotype is, you look at all the stuff, mental regurgitation, she probably has, she does have diastolic dysfunction, probably has left atrial enlargement. So all this stuff points to this being a left heart problem and treat the underlying problem.
I agree. And that's what I said to them, right? I said, thanks, but no thanks. I'm happy to see her in several weeks and we can reassess when she, I don't know. I always say to heart failure people, could you cath them if you're not sure what's going on before you rapidly diurese them and make her wedge look normal when clearly her imaging would suggest that is not the case. Her right atrial pressure is now 3. And I think with these, I find it helps me a lot if she doesn't have AFib, so we could get this a grade 3 restriction, very little fluid. This person could have had a cath, and had we known about it, could she have gotten a volume challenge or put her feet up or done something? And I'm sure it would have said, oh, guess what? Her wedge is not really very normal at all.
Yeah, I
David?
mean, presumably she came in with a clinical picture of left-sided heart failure. And I'm presuming that they did the right heart cath to assess how good of a job they did with diuresis, and if that was a primary purpose. I mean, they did it. Her RA is 3.
Right.
I mean, I think the relevant issues for someone with this HFrEF is more the long-term management from a preventative standpoint, because sounds like she's maybe at high risk for readmission. And if there are social factors that lend her to being non-adherent with her medications, I think this is the opportunity to sort that out. If she has, prior admissions to this, I mean, she is potentially a candidate for even the CardioMEMS device for monitoring and management. So I think there are a lot of opportunities aside from getting her back on her heart failure GDMT, sorting out whatever social or maybe there are psychological personal belief issues with her not taking medications and other interventions to prevent readmission before we, even land on dealing with a PVR4, especially when the RA is only 3.
Carla?
I will also wonder what the pulmonary pressure would have been if you would have managed the hypertension during the right heart cath.
Yes, exactly. Yeah, so we could have given her some nitroprusside or something else in the cath lab, see if we bring down that systolic pressure, and does the wedge go, what changes? Does all of this go away? Very good point.
Yeah, and then the anemia would need to be addressed because that also,
Yes.
I think that's sometimes overlooked, but what tipped her over is clearly poorly controlled blood pressure, but could you have a little high output, and what's the etiology of anemia, et cetera?
Yeah. I think we'll do another quick case. I'll try to blow through this. So I met this lady in 2018, 45-year-old, pre-syncopal, comes and gets an echo, did have a PFO noted. Her RV, she has had echoes for quite some time, but RV is suddenly very different. RVSP 100 sent to me. She got a cath very quickly and terrible numbers, right? RA not as bad as it could be, I guess, given the other numbers, but a mean PA pressure of 70, a wedge that is not normal at 19. Cardiac output is low with an index of 2.2. PVR is very high. So boom, right? Idiopathic not. Okay, and I'll give you some backstory to be fair. But in my mind, if all things else were normal, I'd say, ooh, I don't care that this wedge is 19 because her mean PA pressure is 70. It would be different if it were 40 and 20 or something. But in this case, in my mind, this transpulmonary gradient is very big. We discussed at the time inhaled versus IV therapy for reasons that will be obvious in a minute. She does use oxygen, and that is not new. Ultimately, she chose the Tyvaso initially for her own reasons, and you'll see other reasons. She actually did really well for about a year and a half. This is, let me go to her backstory first. So she is like a very unlucky person, gets eosinophilic granulomatosis way back and was followed actually by Victapsen for a long time. At age 29, she had chest pain and had terrible coronary disease and a bypass and found to have familial hyperlipidemia. Subsequently, all of her siblings have had a bypass in their 30s. Despite that, for years followed in the cardiology clinic through at least 2012, normal RV and LV. Whoops. Did I do that? And then was following the pulmonary clinic and has some cystic lung disease, but really did very well until now. This is a CT of her, and it sort of hung out like this, so not normal in any way, shape, or form, but clinically stable, PFT stable for years. Let me go back to that other slide. So we put her on therapy. She did well for a couple of years. Then she came back in terrible distress, and we repeat a right heart cath, and it's actually worse and not better, unfortunately. So PVR is now 22, her cardiac index is terrible, and we move on to IV prostacyclins with a little bit of trepidation given her lung disease, right? What is going to happen to this? So this was her echo now. It's not going to play, but I think you can tell that the RV is gigantic. And then her CT looks like this. She did have a spontaneous pneumothorax and managed to survive that also, and looks horrible. But this is her echo, and her echo looks like this now. So we're doing okay. However, I don't know. What would anybody else give this lady IV with these horrible lungs, or was I out of line? No, because this is better, right? But
Yeah, I mean, was it the lung disease or the potential HF?
yeah, no, I was a little worried about both, because at times we had wedges that were drifting up, and so I was a little worried that am I going to create a problem there? I was really worried about the lung disease, and I think in part some of this pre and post capillary is both things, right? She, she's young, but she certainly has, she has a cabbage, so we certainly have a left heart that's not normal. I think this was both post capillary, but also lung disease. And so I was worried that I was going to either fill her with fluid or make her need so much oxygen that we would be in trouble.
Sometimes when that RV is so dilated, the LV is just not going to be able to fill. So there's that impairment of LV function that's not inherently an LV diastolic issue as a primary problem, and it's all secondary to the RV being so big, and that based on that first echo could very well have been the case. Even with lung disease. Personally, I probably have been in this position and where I've used prostacyclin, or if they don't want infusion therapy, even selexipag, and the benefits of that is you can titrate those medications slowly and at low doses and make sure that they're tolerating before you step up, and you're in the position of following them frequently, making sure that tolerance is number one, and then hopefully you reach a point that you do start to get some benefit where the RV's been sufficiently unloaded and the LV looks like it's able to fill and function a bit better.
I mean, I think that I don't think many would question your management in this case, honestly, based on her hemodynamics. And but I mean, there are more people like this that we see who would it be different if their mean PA
right, if
pressure
their mean
was
PA is
45?
45 or something. Exactly.
And you have those lungs and you have the cabbage history, then I think it gets more challenging, and it's the cliche. It ends up being an individual decision, but in this case, I mean, you had to do what you did.
Yeah, and that's where I think we're likely to see those people in between.
Can you go back to the echo prior? I thought that it was really compelling looking at the atrial septum and the way the right atrium looks compared to the way the left atrium looks. And we have folks, this was a more complicated case than many, but sometimes you'll have a very young patient, newly diagnosed is usually where we're seeing it, and it looks terrible, and you're having to make a call right now about IV therapy, and you have a wedge that's high. And I'm always reassured when the atrial septum looks like that, because it nearly always is the pericardial restraint and the high filling pressures globally that's driving that.
Right.
So I think that part was reassuring to me. Now, the lung disease, you'll get away with it but
Yes.
you'll make them more hypoxic more often than not. And so if you're trying to get to transplant and keep them alive, yes. My experience with IV therapy is I make people miserable. I do keep them alive. Some of them want to go in hospice after they get turned down for transplant. They're like, take me off of this because I can't leave the house anymore. I'm now on 10 liters of oxygen continuously. I used to be on 4, and this is not going well. So I'm curious how it went in your
She
case.
remarkably has stayed on 4 to 6, and it didn't. Luckily, it did not change. And she actually feels so much better that even at times when she does use more oxygen, she's really being active. She doesn't care because she can actually. She's not in failure. Yeah.
Yeah, to that along the same lines, you didn't mention PFT, so I don't know how bad her lung function was and what her diffusing capacity was.
It is diffusion capacity is really low. She has a mixed restrictive obstructive pattern. I want to say her volumes. She has sort of a elevated dead space, kind of a dead space. But I would say I think her FEV1 is 55% or something.
And then the other question would be any functional testing of her heart before starting on it. Look for ischemia, right? You said one of her graphs.
Yes, we did look for ischemia. She did. She had a cath. All her things were open. Yes, we did look at that too.
Okay.
Yeah.
I know that you probably did the right heart cath, so it was well done. But if this is someone that I'm seeing in the community, and I see that wedge that is elevated, the first thing that comes to mind is this a real wedge? And especially in patients with lung disease where they have so much respiratory variation, we always check at the end of expiration, but there's some articles now that maybe you should check it through the respiratory cycle, which is going to be much lower for these patients. The second part is I do think she has a predominant vascular phenotype based on all the data. So this is someone that probably I would have done the same thing, put her in the hospital, challenge her with ipoprostenol, which is a very short-acting drug. And if she developed any worsening hypoxia, I can turn it off, and I don't need to resuscitate her for 5 hours like Remo, and then transition her to another therapy. But looking at that cath, I would have been worried. Is this a true wedge?
Yeah, I was going to say there's a certain amount of empiricism sometimes, and this was mentioned earlier, where the truth is you don't really know. You have all this information. So, and I'll tell patients that and say, you start them on therapy. Obviously, if her oxygen requirements go up dramatically, and you're ginger with it, then you stop.
Yeah, and that's the nice thing, obviously, about IV. They're coming in the hospital. You can watch very carefully. I think we need to move on to the next topic. Thank you guys so much. I'm going to send you some patients, Ben.